Good afternoon, everyone. First of all, I would like to thank my dear Professor Dr. Aisha, who is not here today, and my dear Professor Dr. Nabil and all of you for this chance. Our base presentation for today is a case discussing is it atopic dermatitis or inborn error of immunity. Our patient is a female patient. She presented to us for the first time in November 2019. She is a 14-month patient of consanguineous parents. Since birth, the patient had severe extensive eczema since birth, all over her body, all over her face and limbs and neck. And then at 6 months, the patient had a history of recurrent upper respiratory tract infection, bilateral draining ears, so wrist infections and eczema. At 12 months, she had period attacks of recurrent fever and frequent bloody diarrhea attacks. She did CT test as normal and CT parallel the sinuses showing sinusitis. And here are the photos of the patient with extensive eczema over the neck and face. The breast highs are normal. The patient had only draining ears, no organomegaly or lymphadenopathy. And here are some photos for the eczema too. Our patient in December 2019, 1 month later from the presentation, she presented with skin rash, which is a vasculitic rash, and swollen hands and fingers. At this point, the patient was treated only by antibiotics and antihistaminics, some oral steroids. She improved, and then she was diagnosed as a case of FMN disease. She had a heterozygote mutation, but this doesn't explain all the presentation of the patient. And here, at the age of 7 years, she was following up with us. The eczema is still there and more extensive. She had mainly in both upper and lower limbs and face and neck, some warts and lesions, but there is no history of enrichments, pneumonias, or any skin abscesses, and the patient had very itchy lesions. So, till now, what we are thinking about, could it be atopic dermatitis simply, or we have to go more deep and think about an inborn error of immunity? That if it's atopic dermatitis only, this does not explain the vasculitic rash and the attacks of infection she had. And if she is inborn error of immunity, so we have to go more deep in her family history. So going through her family history, she had two similar conditions, but with different clinical heterogeneity. She had an older sibling Millie with chronic eczema, cutaneous void and abscesses, which is quite different than our girl. And the cousin who had a severe clinical manifestations, persistent eczema, arthralgia, osteomyelitis, sinusitis, and who unfortunately died with infections without being diagnosed. So at this point, do we think we have to screen our patient or not? Yes, we have to. It's not a simple eczema or simple atopic dermatitis or food allergy. So we did so, and the investigation revealed the case of combined immune deficiency with slight anemia and eosinophilia. And here we can see that the immunoglobulins are high, IgG high, IgA and IgG too. We were thinking about what could this patient be. Could it be a case of combined immune deficiency? Could it be a case of hyper-IgE syndrome? Yes, we thought about this. We did DOC8, it was normal, and we were thinking to do further investigations, and we did really NGS panel, and here is the surprise. The patient was diagnosed with a new category, which Professor Dr. Daria was talking about. She was diagnosed as ARPK1B deficiency, which is a human actin-related protein complex. This leads to a variety of clinical manifestations, as we are going to discuss now. This protein is very important for the dynamics of cytoskeleton. This may explain why the patient had a heterozygous mutation in NFEV gene, which is the same, affects also the cytoskeleton of the cells. That's why the patient had those presentations. It's an autosomal recessive combined immune deficiency disease. We had CD4 low and CD3 low and CD4 low. It's classified as combined immune deficiency with congenital thrombocytopenia. The patient had many of those manifestations: eczema with allergies in the form of bloody diarrhea and extensive eczema. Thrombocytopenia we didn't have in this case, but might be. They have an effect in platelet aggregation and migration due to the cytoskeletal effect, as we said. And also bleeding episodes, the bloody diarrhea and vasculitis too. And also the periodic fever. This explains the recurrent attack of fever she had. Also, the patient had the immunoglobulins B11 high and IgA, T-cell lymphopenia and low numbers of naive T cells. And also, which is very obvious in our case, that the patient had significant heterogeneity in her family history. Thank you so much.